Good morning.
Good morning.
Hello. So thank you for the very kind introduction, Vijay, and a huge thank you to you and to Karen for inviting me and giving me the privilege of having this time with you this morning. So it's a delight to have the opportunity to have a conversation around the issues that face you in primary care and dentistry, and to learn from you. One of the things I'm involved with at the minute is working with the General Medical Council to understand mental health of doctors and the pressures on staff across the health service, but particularly GPs, people working in primary care. So it's a great opportunity for me to have a conversation like this. And our focus is on how we can change the working conditions of people that are creating the problems. And I guess I just wanted to start by saying a little bit about, well, not saying so much, but just acknowledging what some of those key problems are in primary care, taken from the King's Fund publication, Understanding Pressures in General Practice. I'm not going to go through these with you because they'll be clear to you from your own experience. Actually, the level of increasing demand on primary care over the last few years has been really pretty extraordinary. You know, estimates vary between 16 and 25% over the last 4 or 5 years, along with a declining workforce. For example, general practitioner numbers are declining, and over the last 15 years or so, while hospital consultants have grown in number by about 38%, general practitioners have declined in number over that period, despite all of the continuing commitments from national bodies about growing primary care in comparison with secondary care. And you'll be aware of difficulties around recruitment and retention, and people working part-time just because it's too painful and difficult to be working flat out full-time day after day in terms of quality of life and day-to-day experience. Can you hear me at the back? Yeah? And the challenges of getting sufficient people to work in practice nursing and practice management. So again, problems of declining numbers and people wanting to go part-time rather than full-time. The lack of funding and intelligence for primary care, so NHS England not gathering the kind of data which would have told us about the development of these problems a lot earlier, and now we're in a crisis situation. So it's been a bit of a failure of the centre in terms of gathering information. Anyway, and you'll be aware that last week the NHS long-term plan was produced. What is that joke about plans? I like these plans that come along and then they go whoosh by and another one comes along a little while later. But the plan is for an extra £4.5 billion for primary care, and the creation of primary care networks, so that these networks of primary care teams will serve 40 to 50,000 patients, and they'll be located within integrated care systems. And I think the plan is to have 44 integrated care systems across England, and to reduce the number of CCGs to have one CCG for each integrated care system. So this is a kind of structural change. I think a lot of people must have done a lot of Meccano work when they were young, because they like creating structures and changing structures, but in the end that's not what's important. What's really important is the culture of our organisations. And there's a commitment to producing 5,000 more GPs. So that's kind of a wonderful commitment, but it's how we make that happen in practice, which is going to be challenging. Practical support for innovation, use of new technologies, encouraging support staff like pharmacists to do more medicines reviews and to look at people's storage of medicines, having advanced nurse practitioners to work with people with musculoskeletal problems to reduce the pressures on general practitioners. There's not much about dentistry, I don't see, in the long-term plan, which is the dental practice here. Yeah. Have you seen much in the long-term plan about?
5 words.
Yeah. Yeah. Yeah.
Sure, it's 5. That's what I've heard. It's a record. But
So 5 is an upper record, or
it is, yeah.
yeah.
Normally it's 1.
Yeah.
Token.
Yeah. Yeah.
More than 1's good.
Yeah, and we know the pressures on dentists in the system, and the levels of stress, and some worrying evidence around suicide levels as well because of the pressures. And we see that right across, I think, the workforce in the NHS. Commitment to reducing the bureaucratic burden, and developing new models of general practice at local levels, and new contracts. So those are some of the kind of highlights in the long-term plan that apply to primary care. But as I said, I think that the really important issue is changing culture in organizations, not changing structures. Changing structures is kind of the easy bit to do. Apparently, it's changing culture that matters. So it's that I really want to focus on with you today. So I guess for me the starting point is to say that I think the most significant aspect of the NHS landscape is that we are damaging the health and well-being of the people we ask to deliver care for those in our community. So we have this aim, which is to promote the health and well-being of the people who live in our country, in our communities, in our society. And that's really important. We want to make their health better, quality of life better. But in the process, we are damaging the health and well-being of the 1 in 20 people in our national workforce who work in healthcare. If you take social care as well, we're probably talking about 1 in 10 of the entire working population. That cannot be right. That with an organizational purpose of promoting health and well-being, we're damaging a significant proportion of the population. And it's not minor damage. We're talking about the fact that 50% more staff in the NHS suffer from debilitating levels of work stress compared with the general working population as a whole. We know that around 27% of NHS staff score above a cut-off point, indicating minor psychiatric morbidity because of the levels of work stress they experience. And we know that work stress is generally not episodic, it's chronic. So the normal test-retest correlation between stress levels over time is around 0.6 for people. So it's not episodic, it's chronic, and chronic work stress is hugely damaging to health and well-being. So we know it's associated with cardiovascular disease, with early mortality from cardiovascular disease, with addictions, with depression, with diabetes, and so on, and with early mortality. And we know it affects people's ability to be compassionate. When I'm feeling hugely under pressure, it's very difficult for me to be present and compassionate with those I'm seeking to deliver care for. And we know that it affects error rates as well, that people are more likely to make errors high. So we know in the secondary care sector that high levels of work stress in a hospital trust are associated with subsequent higher levels of patient mortality and lower levels of patient satisfaction. So it seems to me, I think this is the most significant characteristic, if you like, of the landscape of the NHS. And it's not sustainable to go on piling more and more work pressure on a workforce that is already desperately overwhelmed. And we also know it doesn't need to be this way, because we know that there are examples of, for example, NHS trusts that have reduced stress levels of their staff and maintained them at a low level. We know there are examples of primary care organisations that have been very successful in reducing levels of stress and maintaining them at a lower level. So it doesn't need to be this way. And so, you know, for me, the starting point in thinking about all of this is to say, well, we need to step back and think about what it is fundamentally we're trying to do here. And when we created this NHS system in 1948, it was a post-war society that made a commitment to providing high-quality care for everybody who needed it, regardless of their wealth or status or background. And I think that the core values of the NHS at that time were to create a compassionate and inclusive system. And I think those two values of compassion and inclusion are at the heart of the NHS. And all of you and the people you work with and the people who work across the NHS have made a commitment to dedicate a huge part of your precious, unique lives to caring for those around you. So you too and the people you work with embody, I think, a core value of compassion. And, you know, compassion is a lovely word. I think that understanding that it's the core value of the NHS has implications for how we behave within the service. It has implications for the culture. Compassion for me is the GP from Southwark who told me she had danced in her surgery that day with an elderly, lonely man when she discovered they had a shared interest in dancing. Beautiful. And then referred him to a local dance group. And she told me recently he's coming back regularly now to have another dance lesson. Anyway, and it's the healthcare assistant I saw who sat for an hour after her shift had ended in a hospital holding the hand of an elderly lady who was in some distress and talking to her lovingly and caringly until she was calm again. But probing a little deeper, I think it has compassion has 4 behavioural components. So if what's your name? Tasneem. If you're in distress, then for me to be compassionate, first I have to be present with you. I have to pay attention to you. So I have to be here and now with you. Nancy Klein uses a lovely phrase, listening with fascination. I have to listen with fascination to you. So the first behavioural element of compassion, I think, is attending, is being present. And second is I have to understand what are the causes of your distress, ideally through a dialogue with you. And third is I have to have an empathic response. I have to feel your distress at some level. When we think of compassion, we think of a feeling element. And what that feeling element does, as long as I'm not overwhelmed by the feeling of distress I get in mirroring yours, is it gives me the motivation to help or serve, which is the 4th step. So attending, understanding, empathizing, and then helping or serving. Make sense? Those 4 elements of compassion. And we know that when staff behave compassionately, with compassion towards patients, that patients are more satisfied with the care they receive. And that has an impact on staff well-being and commitment as well. So you get virtuous cycles of compassion. Compassion's about blurring the boundaries between self and other. So the challenge for us is how do we create the conditions in our organisations for staff to deliver the high-quality, compassionate care that they want to deliver, that patients want them to deliver, and that we and the system wants them to deliver. And the answer to that is, as I said earlier, is what we know about behaviour in organisations is the most important influence on behaviour in organisations is culture. And what does this mean? Culture is the way we do things around here. Or as somebody said to me recently, a better definition is, it's the way we do things around here when no one's looking. It's beautiful, it's good definition. It's the unwritten, if you like, almost the unwritten rules, the norms of the way we behave. So every interaction by every one of us every day shapes the culture of our organizations. So how warm we are, how optimistic we are, how cynical we are, how irritable we are, how compassionate we are, every interaction shapes the culture of our organizations. But the role of leaders in primary care, for example, practice managers, GPs, is particularly powerful because people in our organizations are vigilant about what we pay attention to, what we talk about, what we monitor, what we reward, and particularly what we model in our own behaviors. So if we're to create cultures of compassionate, high-quality care, then as leaders we have to embody compassion in our leadership. And what that means in practice is those 4 behaviors. So us as leaders, paying attention to those we lead, listening to those we lead with fascination. Secondly, it's seeking to understand the challenges that they face. So not by our imposing an understanding, but through dialogue with them, seeking to understand the challenges that they face. And third, it's empathizing. So given what I said about levels of stress and difficulty that staff are facing, it's right that leaders should be empathizing. And we know that emotional intelligence is a key predictor of leadership effectiveness. And fourth, it's about helping or serving. So you know, I think the most important, well, a couple of things that I hear from staff across the NHS. The first is they say, we only ever see our leaders when something goes wrong. That's one complaint. Another complaint is our leaders are really good at coming around and talking to us and being sympathetic, and then they go away and nothing changes. So it's still the same. So I think that, you know, the most important skill of leadership is listening. Is truly listening to people, being present with them. And the most important task of a leader is helping or serving. How can I serve? How can I help? As a leader, my job is to enable you to do the job that you want to do, we want you to do. What can I do to help? That's the most important task of a leader. So, that's the most important thing I wanted to share with you today. So in looking across the NHS, what we've identified is what seem to be the really key cultural elements in any organisation. So when we look across primary care and secondary care and say, well, where are the outstanding organisations? What characterises them? We see these 5 elements, and we see them consistently. And so another way, by the way, of thinking about leadership is we can think about leadership as having 3 functions. Leadership is about creating direction, ensuring direction. Leadership's about ensuring alignment of efforts in relation to that direction, and leadership's about ensuring that we have people's commitment, their trust, their motivation, their goodwill, their energy, their creativity. So leadership's about ensuring there's direction, alignment of efforts around that direction. That means that people's efforts people's work is focused on the direction we're going in. It's not being dissipated in other directions, or they're not wasting their time doing things that aren't really contributing to that core direction, and then ensuring as well commitment. And the first 3 of our key elements actually match with direction, alignment, and commitment. So I'll talk about those 3 first. The first one, this might sound like just more managerialism, but we know from all of the research on people at work that it's really important that people feel that they know what it is their team or organisation is seeking to achieve. We need to feel clarity about what it is we're there for at work, and we need also to have a sense of value fit. I need to feel that my values as a person are in accordance with the values of the organisation I'm working for, so that I feel proud, committed, I have a sense of consistent identity. So, of course, every NHS organisation has a bunch of fine words on its website. This is from Salford Primary Care Together Health. Can you see it at the back? Yeah. So this is the kind of vision statement. I think it's great. Everyone who lives and works in our area can live healthier, happier, and more fulfilling lives, so that they can start well, live well, and age well. That feels wonderful. That feels, wow. If I was spending my work life seeking to achieve that, I would feel great. But what we know is, from looking at various organisations in the NHS, is they all have more or less a bunch of nice words on their website, whether it's a primary care organisation or a trust. They all have, there's some people who are really good with words out there, inspiring words. But what we've also seen from the work we've done is that it's really important that leaders embody a commitment to that vision in their day-to-day work. So if that's the vision for the primary care organisation, then what leaders need to be doing is continually coming back to saying, this is our purpose. We are here to ensure that people can live these really healthy, fulfilling lives. That's what we're here for. It's like an anchor. You know, you drift away in the boat, and the anchor of the vision statement pulls you back. And that you, but as leaders, what we talk about, what we pay attention to, what we monitor, what we reward, what we model, tells people what's important to us. For example, one of the really exciting things we got to do was to, because we wanted to find out what the senior leaders in trusts talked about. What do they talk about? So we got the board meeting minutes for 71 trusts over an 18-month period of their meetings, and we analysed the content to find out what they were talking about. 80,000 pages of the most exhilarating material you can possibly imagine. And we found that very often they were spending far more of their time talking about productivity, cost effectiveness, financial performance, the visits of the regulators, than they were about quality of care and safety. And where that was, the more that was the case, when we looked at the staff survey results, the less committed, the less engaged, the less trusting staff in those organizations were of their leaders. So it's really important that we're clear in our organization or our primary care team or our dentistry team, what is our core purpose here? What is it that we're seeking to achieve? And that we as leaders are making sure that we're continually using that as a base, as a kind of value base to reinforce what it is we're trying to achieve. Does that make sense? So the second point is about, and by the way, what is the vision of your organizations? Do you have a clear vision statement in your organizations? Yes? Yes? Yeah? Yeah? Do you know what the vision of your organization is?
Every time I recruit somebody, I tell them our job is to make other people's lives better.
Yeah. 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 There's something about reinforcing that core vision, so people are clear about direction. And the problem with senior leaders spending their time focused on financial performance and the regulators and productivity is that it communicates the message that that's what's important to us, whether it's at strategic or operational level. It communicates the message that these are the things that are most important, and that sucks away, if you like, the commitment and the clarity, because we know that clarity of direction is really important for people's well-being in organizations. And we also have lots of statements about values. Values are what's important to us in an organization. I think the way that values are used in NHS organizations is it's often just a bunch of words on a website, and it's not understood that means that that's what we want people who work in our organization to continually model. So the issue is how we translate values, communicating to people what's important to us, compassion, learning, innovation, collaboration, being cooperative, being helpful, how we communicate that that's what really matters in terms of our ability to deliver high quality patient care, how we translate values into the genetic structure of the organization. So here are the values for Salford's Primary Care Together network. And what we've been doing is developing tools where values become key in terms of both performance management, selection and recruitment, appraisal, so that it's built into all of the processes in the organization to reinforce those values of compassion and collaboration. So ensuring that all of those who work within the team or the organization understand that these are the behaviors that we want to promote and reinforce. That's why it's very useful for both vision and values to involve all of the staff in developing those statements, so that they're contributing to what the vision is and shaping it. So we see in organizations that have really clear statements of direction, of vision and values, that they are more effective in delivering high quality, continually improving and compassionate care. And the second point, the second cultural element, is the importance of alignment. So what we see across the NHS, Tamsin, as you said, is that people are overwhelmed. There are so many priorities which are being determined by national organizations, by local organizations, and we've come to call them the priority thickets. There are so many priorities that people can no longer see clearly what's important and are just overwhelmed by tasks. In the most effective organizations, we started looking at primary care back in the 1980s, and one of the consistent findings from our work in primary care teams over the subsequent, 30 years, is teams that have clarified what their objectives are, 5 or 6 clear objectives, are much more effective than teams that don't. And so we see in every organization that simplifying is part of what makes primary care organizations and other organizations really effective, where leaders simplify, where they make sure that teams and sub-teams are clear about what their objectives are, and make sure that every individual within the team is clear about his or her role and what their objectives are, that those organizations are much more effective and have much lower levels of stress. So we know that work overload, role ambiguity, role conflict, teams without clear objectives, in those contexts, stress levels are significantly higher. So if you take the last 60 years of research on human motivation and performance at work, what it shows is, and this is a rather kind of banal conclusion, but the most important predictor of people's motivation and performance at work is whether they've agreed a limited number of clear, challenging objectives for their work. It's kind of banal, but it's evidence-based practice. And the key words there, you'll all be familiar with the SMART acronym. You're all familiar with that. It kind of mirrors what has been demonstrated in all of the research on goal setting. It's about making sure that goals are agreed rather than imposed targets, because people are more motivated and committed when they've agreed goals, and teams are more motivated and committed when they've agreed goals as teams. It's about making sure that they're clear, but it's also about making sure they're challenging. What the SMART acronym misses out is challenging. If we're truly in the business of making sure that everyone is able to live fulfilling lives, to live well, to start well, to age well, then we should be setting challenging objectives. We know that people are more motivated and perform better when they have challenging objectives. So it's about making sure we're translating the vision into clear objectives at team level and for each individual within our team. Evidence-based practice. This is not some managerial ideology. This is evidence-based practice. The less teams have clear priorities and objectives, the less they've simplified, the more stress people are under within those teams, and the less effective the teams are. And it's also about making sure then we're gathering data which we can use to give people feedback and teams feedback on how well are we doing in terms of making progress towards these. So the third point is the importance of creating commitment. And that's about, of course, leadership. We reviewed all of the leadership literature a couple of years ago, well, 2015 now, and published a review with FMLM, the Faculty for Medical Leadership and Management, and the King's Fund. So we reviewed all of the leadership literature, but also the literature specifically on healthcare. And what we concluded was from that these are the kind of core behaviors of effective leadership. It's about being authentic. It's about being honest and open, having integrity. It's about having humility. So, you know, we know that a lot of senior leaders in the system, well, if you take, for example, the levels of narcissism as a personality trait in the general population, it's about 1%. But among senior leaders in organizations, it's about 8%. And what we know from the research literature is that humility is a really important characteristic of effective leaders. Not some kind of obsequiousness, but a humility that says, how can I lead you better? How can I be more effective? What should I stop doing as a leader? And it's also about being optimistic, creating a sense, as you say, of positivity, and inspiring people to think, yeah, we can be effective, we can make this better. It's about compassion and it's about appreciativeness. Appreciativeness is so simple. It's about saying thank you to people. The most frequent complaint I hear from NHS staff is, apart from service users and patients, no one ever comes and says thank you to us or shows appreciation. And the interesting thing about gratitude, or expressions of gratitude and appreciation, is that we consistently underestimate the impact of expressions of gratitude on the other. So the research tells us that, you know, if you're going to say thank you to your colleague, what's your name, sorry? Wendy to Jay, that you think it will not have a big impression on Jay, but when we ask Jay afterwards, it has a much bigger impression than you possibly imagined. So I'm sure everyone in the room is really good. I'll tell you another quick story. I remember once, very early on in our work in primary care, we were doing some fairly intensive work with a small sample of primary care teams, videotaping their meetings, things like that. And one of the receptionists told us that what they found really difficult in the practice was the lead GP went in every morning and walked past the reception desk and never said good morning. And they just found it really, they didn't understand it, they found it rude, lacking civility. And when we experience incivility, it has a pretty dramatic effect. Anyway, one of our research team took it upon herself to tell the lead GP about this. And he said, oh my God, I had no idea. Really? And then 2 weeks later, we got a call from the practice, and in the course of that, they said, you wouldn't believe it, he's bringing in chocolates, biscuits, every day now. It's incredible. So let me just show you some data. Well, it's not really data, but just to show you that this is not ideology. We introduced a staff survey in mental health services, ambulance services, community mental health services, hospitals, the acute sector in 2003. We've got 15 years of data from 250,000 people every year. And that gives us great insight into how the NHS is changing. So we know that the percentage of people excluding primary care, and I think we should have a national survey for primary care. In fact, we've designed one that predicts CQC ratings, saying that in passing. And it's free, and I'm trying to get somebody to put it on their website. It doesn't matter, I think, whether it's RCGP or CQC or whomever. We've got a great questionnaire that predicts CQC ratings. Anyway, there's nothing for primary care at the minute. In secondary care, we have 250,000 responses, 15 years. We can do the most sophisticated data analysis. What we see is that over time, the NHS staff, 66% said they had an appraisal conversation in 2003. It's about 88% now. The percentage saying that the conversation was helpful hasn't changed over that time. It's still 38%. Yet the quality of the appraisal conversation predicts subsequent levels of engagement. A poor conversation engagement seems to be significantly lower, a good conversation significantly higher. But it also means that we can find the organizations that are doing things well. Good appraisals, high levels of engagement, low levels of stress. Most importantly, what it enables us to do is to link data from staff experience to national outcome data like care quality, financial performance, patient mortality, patient satisfaction. There is no better predictor of trust performance, nothing comes close, than staff experience. Staff experience by far and away the best predictor of trust performance. So what we see is, this is a very crude summary, is that staff views of their leaders predict patients' views of care quality. Where staff report high work pressure, as you've been talking about today, patients say there are too few nurses, they're not given the respect that they want, they're not treated with dignity. Where staff report high levels of stress, and do you remember what I said earlier about the percentages of staff suffering from chronic stress? Nearly 40% every year in the secondary care sector report being unwell as a result of stress at work during the previous year. When staff report high levels of stress, subsequently care quality is significantly worse, financial performance is significantly worse, patient satisfaction is significantly lower, absenteeism is higher, and so on. So it's really clear that staff experience is fundamental to the quality of care that we provide. So and this is not simply correlation analysis. We're able to do the most sophisticated statistical modeling over time to show the direction of these relationships. And staff engagement is the most important factor in predicting the performance of these organizations. In fact, last year, Simon Stevens, who's the head of NHS England, asked us to look at the relationship between staff engagement, how engaged staff are, and spend on bank and agency staff, because you know that's a major problem. So we have a 5-point measure of engagement in the staff survey. What we found was an average shift upwards of 0.12 on the 5-point measure of engagement is associated with savings of £1.7 million annually for the average trust in terms of bank and agency spend. Makes sense? Because the higher the levels of engagement, the lower the levels of absenteeism, the lower the levels of bank and agency spend. But we also, I think the other thing that's important to say in terms of this third area, which is about commitment, is that it's primarily about the emotional environment that we as leaders create in the workplace. And you talked about being positive and going in every day and being positive. What's your name, sorry? Liz, yeah. So, and it actually is really important. We know that there's been a wonderful randomized controlled trial that shows, Richard, do you like chocolate? Yeah. That if you induce positive emotion in Richard by giving him chocolate, he makes better medical diagnoses. Sorry? What is? Bacon's more effective, yeah.
Oh, they bring you cups of tea.
Yeah, they'll keep bringing you, they'll bring you cups of tea. They'll keep bringing in bacon sandwiches now with a slice of chocolate in the middle, probably. So positive emotion is really important in human. We are primarily emotional creatures, not cognitive creatures. We think of ourselves as being primarily cognitive, but we're primarily emotional. And it's the emotional environment that we create in our organizations which makes a profound difference to their functioning. So if you have, when people feel positive, they're more creative. If you induce positive emotion in a 3-year-old and give her paper and paints, she'll produce more creative paintings, and the same is true of 63-year-olds. We are more creative, we make better decisions when we feel positive. So if you have positive leaders of teams who create a positive emotional environment, then those teams are more cohesive, more cooperative, show more compassion. But this is not about coming to work on a Monday morning, Liz, you know, in some Ken Dodd type persona. That's where you're going wrong, yeah. It was the hair, I think, yeah. It's about being authentic and being genuine, being honest and open, having humility, being appreciative, optimistic, compassionate. So you create positive environments that way as a leader. But it's also, and it's also about, as I said, if you have within the team individuals who behave in intimidating or aggressive or domineering ways, then that's going to corrode the emotional environment. And I see very often in primary care teams behaviours that have been tolerated for years and accepted. And so the message that goes out to the new people coming in is, yeah, that's the way we do things around here. That's part of our culture, is tolerating those behaviours. And it is about, I think, it is about not leaping to be condemnatory, but seeking to understand. I mean, what we've found in our work in primary care is most of the problems people attribute to personalities are to do with lack of clarity of objectives, or unclear roles, or conflicts over hierarchy within the teams. And when those are dealt with, a lot of the personality problems disappear. But we have to deal with those behaviours, because if we tolerate them, then that affects the emotional environment of the team and its ability to be effective. So, thank you so much for coming back. It's always reassuring. The other aspect of the emotional environment I wanted to mention was the importance of processing negative emotions, and that people in healthcare often experience really traumatic events or periods of time in their work. And giving people the space to talk about and validate and legitimize, as it were, those negative experiences, we now know is really important for mental health and well-being and compassion and so on. So Schwartz rounds, are you all familiar with Schwartz rounds? No? So Schwartz rounds were developed in the US by an oncologist who himself developed cancer. And and he observed that it seems really important for healthcare staff to be able to talk about the negative experiences they have. I mean, I've been in a mental health trust on a day a service user took his own life, and the effect on the staff was devastating. I've seen, been in an acute hospital when a neonate has died in intensive care, and the experiences are devastating for staff. And so Schwartz rounds were introduced as a way of people coming together with lunch to talk about negative experiences they've had. With lunch seems to be important. And actually it is significant. There's been an RCT of commensality amongst doctors. When doctors in hospitals have lunch together, care quality goes up. Interesting. Anyway, bringing people together over lunch for a group of staff to talk about negative experiences. It's not a problem-solving exercise. And there was an NIHR study in this country published last February that showed that staff that attend these Schwartz rounds regularly, the percentage of people reporting very high levels of stress drops from 25 to 12% when they attend them regularly. And that's a huge shift, and it is consistent with findings from the States about Schwartz rounds too. So there's something about making sure we're giving people the space and time in our organizations to talk about the negative experiences they have, whether it's a receptionist who's been aggressed against by a patient, or a GP who's had a really difficult consultation. But we're making the time for people to talk about this stuff together. And if you don't have time for coffee or for lunch, and you certainly don't have time to put in place the space for people to talk about these issues, but it's really important for mental health and well-being, and thereby for the delivery of quality patient care. So the fourth point, and forgive me, I've used up all of the time nattering on, so we haven't got time for a meditation practice. I should be practicing what I preach, but you've got to have lunch at some point before 3 o'clock. So I'm going to push on to the fourth point, which is about innovation and learning and quality improvement. We're only going to respond to the challenges that face us if we develop new and improved ways of doing things, of course at national level, but also at local level. And looking at the literature on innovation, we published a paper in the King's Fund, I think it was the year before last, called Caring to Change, based on our review of the innovation literature. And what that showed was that compassionate leadership is really core to innovation as well. So where you've got leaders who are focused on the vision of the organization as about transforming the lives of patients, that really reinforces the fundamental altruism and intrinsic motivation of healthcare staff, the people who've chosen to work in health services. But also where those leadership behaviors are being displayed, then people feel it's safe to take risks within safe boundaries. And it creates what Amy Edmondson has called psychological safety in teams, so that people feel safe to talk up about errors and concerns and issues, feeling afraid about their competence, feeling afraid about a decision they've made, a mistake they've made. And when we talk about those issues, then we've identified areas for innovation. Innovation is not about coming up with some great new glitzy idea. Innovation really fundamentally is about problem solving. Here are the problems we face. And when people feel safe in teams, they're more likely to talk about errors, concerns, and so on. So that's what we as leaders do, is to create a sense of psychological safety. And we have abundant evidence from Amy Edmondson's work at Harvard showing how healthcare teams are much safer in terms of practice when there is an atmosphere of psychological safety. But it's also all of the work we've done. I mean, we started looking at innovation in primary healthcare teams in the 1980s, as I mentioned, and looking at innovation in healthcare generally. And what we found is that the more hierarchy, bureaucracy, dominant leadership, command and control leadership, the less the innovation. Makes sense, doesn't it? People are not likely to try out or come up with ideas for new and improved ways of doing things if you have lots of hierarchy, bureaucracy, or dominant leadership. So it's about how we create more autonomy and collective leadership. It's moving from leadership being the responsibility of one person or two people to everyone feeling they have leadership responsibility. When we look at climates and cultures for healthcare excellence across the world, what we see is command and control is pretty much the worst form of culture, leadership culture you can have. And actually having individual, heroic, charismatic leaders is not very helpful either, because they kind of disempower everybody. It's helping to create an environment where everyone feels they have leadership responsibility. It's the Band 4 administrator I saw from East London Foundation Trust presenting recently at a major London conference, the quality improvement project that her team had introduced. But it's about shared leadership in teams. So we know from the research on teams that the more there is shared leadership in teams, the more effective teams are, whatever the sector. So though Wendy may be the hierarchical leader of the team, when Jay has the relevant skill and experience, that the leadership seamlessly shifts. So, it's about leaders facilitating people's involvement and input into teams. Another thing we know about really effective teams and team meetings is that the more people are inquiring and asking questions rather than advocating positions, the more effective those teams are and those team meetings are. So we're seeking to understand where each other is coming from or what the ideas are, rather than pushing our particular position. So it's about shared leadership in teams, and it's about interdependent leadership where we are prioritizing care overall, not just our individual areas of responsibility. I've done my job. It's about prioritizing care overall, where we take responsibility for care overall. Everyone in the team, to go back to your point, what's your name? Pearl. To go back to your point, it's about everybody taking responsibility for provision of care, and it's about consistency of leadership in teams. So it's no good if James is this warm, positive, compassionate, kind, caring, supportive leader in the team.
I need another example.
Yeah. And then in the next room is VJ, who's this dictatorial, tyrannical despot. We have to have consistent approaches to leadership as far as possible, and that's about making sure that we're reinforcing the values and the behaviors through appraisals and how we select people. In the best functioning organizations, what we're seeing is that the appraisal conversations are focused around values first and foremost, not around technical competence. Are you behaving compassionately, respectfully, with civility, collaboratively, cooperatively? By the way, I didn't mention earlier that one of the key factors in terms of team effectiveness is a commitment to working cooperatively across boundaries. So we think every team should always have as one of its 5 or 6 objectives improving the effectiveness with which we work with other teams or organizations for the benefit of patient care. And it's also about listening, to go back to these factors that are important for innovation. In the NHS, there's lots of focus on quality improvement skills and a commitment to supporting quality improvement, but we tend to neglect these other areas. We talked about vision, I've said a bit about autonomy, but it's also about hearing all voices within our team. So we know that, for example, diversity of frontline staff, well, to the extent that an organization reflects the diversity of its population in healthcare, the better is care quality and the better is the financial performance. So we've looked at census data and correlated that with the mix of staff in secondary care, and the better the representation or the reflection of the community, the better the trusts perform. And one of the reasons is that diversity, when we hear all voices and value all voices, that's the stuff of creativity and innovation. We know that from work on homogeneous and heterogeneous teams. The more we hear different voices, whether it's differences of functional background, demographic background, culture, ethnicity, the more we value all voices, the more innovative and productive our organizations will be. The NHS, had a core value of inclusion. I think it's what it was created for, but it's still the case you're 1.5 times more likely to be appointed from selection panels if you've got white skin than if you've got dark colored skin. And in some organizations, you're 12 times more likely to be involved in disciplinary processes if you've got dark skin than light skin. It's a disaster. So I kind of feel that every one of us in every team has responsibility for creating positive attitudes to diversity, excuse me, not just as a moral issue, but because we know it predicts effectiveness as well and innovation. So I think it's the responsibility of all of us to value difference and diversity. We hear all voices. Whistleblowers, for example, we tend not to hear the messages of whistleblowers. Whatever we say in the NHS about whistleblowers must be listened to. I hear stories every week from people who have been speaking up for a long time about an issue and then get chewed up and spat out by their organizations because we tend to shut out the message because we're shutting out the anger. And the reason they're angry is because they've been trying to get the message across for so long. So it's about really trying to listen to all voices in our organizations. And the last thing I want to say about innovation is about addressing for us as leaders, innovation is about addressing the big, difficult, hairy, horrible, smelly problems that we face in our organization. Overwork, stress levels, inadequate premises, poor doctor-to-patient ratio, whatever it is that are the big problems, our responsibility as leaders is to focus our innovative energy on addressing those problems. It doesn't mean we have to find the solutions, but it's about ensuring that we are collectively talking about those problems and how to address them. That may not be possible within your primary care team, but it should be possible and definitely happening at regional level, so that we're raising these issues which are causing us difficulty and continuing to raise them and bringing everyone's attention to bear on those problems. Because if we continue to just let them be, oh, that's how it is around here, they become part of the wallpaper and we accept them. But it's damaging patient care and damaging the well-being of staff. That's what innovation is addressing those big, difficult problems. And the final area is the importance of team working. We know a lot about team working and how it makes a difference to care quality. And I've mentioned already the importance of clear objectives. But we know a good deal about how important team working is to ensuring high quality care. Lots of studies that have reviewed this. We also know that across the secondary care sector, though 96% of people say they work in a team, only about 40% work in anything even beginning to resemble a team, with clear objectives, where people work interdependently and where they meet regularly to review performance and how it can be improved, just taking those three criteria. And the more people working in what we would call pseudo teams, the other 60% of people, the higher the error rates, the higher the levels of patient mortality. In fact, our data show that if we could increase the percentage of staff in the acute sector working in real teams with those three characteristics, clear objectives, working interdependently, meeting regularly to review performance, perpetuous timeout, stillness, if we could increase that from 40% to just 65%, that would be associated at a minimum, taking confounding factors into account, with the prevention of a minimum of 5,000 avoidable patient deaths annually. So quality of team working is not just a nice to have, it's fundamental to the delivery of high quality care. And these are some of the kind of key elements of great team working. I think, by the way, when you have team meetings, your objectives are the agenda. So if you've agreed 5 or 6 objectives as a team, as a primary healthcare team, these are our 5, that should be the agenda for your meetings. Everything else should come under that. Otherwise, why are we talking about it? We talked about most of these, so I'm not going to go through them in detail. And I've told you about the data on taking time out regularly. 38% more productive from taking time out. So I think even after your meetings, just taking time out and saying, how did that go? What went well? What didn't go well? How could we improve them? We've got videotapes of like primary care teams. We've got 25 people in a room spending an hour and a half discussing whether to have a fish tank in the waiting area. It's a very nice idea, but did it need 25 hours of primary care time? Or we've got a team of 20 people sitting in a room and they spend an hour discussing where to hold the Christmas party. It's an important issue, but does it need a half a week's work? So, yeah, just to summarize, dream teams have an inspiring vision, regular and inspiring team meetings. If you've got 20 people in a room for an hour, that's a half a week's work. We've got people come out of your primary care team say to us, it's always like that, it's terrible, isn't it? And you just think, well, why didn't anybody say anything? This time should be inspiring, should be engaging, should be creative. People should come away saying, that was really useful. You know, one of the things we found was that even when the team meetings were bad, that was better than not having team meetings in terms of primary care team effectiveness, because people have little off-air conversations with each other about patients or about issues. So that's a benefit. It's about positive, supportive relationships in teams. If you have, look, interpersonal conflicts are a disaster in teams. They will affect patient care negatively. So we cannot tolerate people allowing their interpersonal differences to chronically get in the way of working effectively together. As leaders, we have to intervene. It can be about, you know, as you were saying, I think, Liz, about giving feedback, then coaching. But ultimately, if people are chronically not getting on, we have to take disciplinary action. Ultimately, they have to leave the team because it will affect patient care. And it's making sure that when conflicts arise, as they will, we quickly work through them in an open, ethical, supportive, compassionate way. But our compassion is ultimately for the benefit of patients. It's about compassion for the communities that we serve. And I've mentioned the difference between inquiry and advocacy, leading into team cooperation, positively valuing diversity, and practicing reflexivity. So as leaders, the key skills are focused around these issues. I'm not going to go through these. My mother recommends that book if you want to learn more about effective teamwork and team leadership. So I've been focused for the last 3 years. I've been working with the King's Fund and the Centre for Creative Leadership in the States and NHS Improvement on designing tools to help organisations get the leadership that they need in place. Because it's all very well for me to stand here and say, this is what you need. Well, how do we get there from here? So we've been developing a whole set of tools which are designed to be delivered by you within your organizations. They are all open source materials, so anybody can use them, any organization, anywhere in the world. They're designed to be evidence-based, so rather than some whizzy idea from a young consultant in Deloitte or McKinsey, they are evidence-based. They're free, as opposed to what places like Deloitte and KPM. Am I starting to sound bitter here? And the aim is that you implement them within your organization. They can be used in primary care. In secondary care, we've got 50 trusts which are currently involved in implementing these tools. It involves looking at our existing culture and leadership, then designing what interventions we need to help develop our leaders now and in the future so that they can create the cultures that we've talked about this morning. And there's a whole range of tools focused around these 5 areas I've been talking about that you can download and look at. So each tool, whether it's setting team goals or compassionate performance management or diversity training or team-based appraisals or values-focused appraisals, each tool covers 5 things. What is this? Why is it important? What's the research evidence? How is it done? And then there are case studies. So you can go there and you can download any of these tools and use them. The website, I think the 2 websites are there. And everyone, you've got a copy of the slides, so you can see where you can go to download the tools and the information. So those are there as a resource for you and your organizations, your primary care teams to use. I feel really privileged that I've had the opportunity to work on developing these over the last 3 years, and proud that we've got something which is publicly available in the NHS, and we're trying to get those implemented in the national organizations as well, so that we are changing the culture of the national organizations. But I want to finish by going back to what I said at the beginning. It is about, what's your name again? Sorry?
Helen.
Next to Helen. Julie. So, you know, it's about self-compassion. But given the strain that general practitioners and primary care staff are under, practice managers, for example, it's really important to take care of ourselves and to know what are the key factors in terms of human well-being. I should be telling you this? The most important factor by far and away to human well-being is spending good quality time with people we love and who love us. You're more likely to die from loneliness than you are from the effects of obesity or smoking. So it's spending good quality time with people we love and who love us. Everything else is kind of relatively insignificant. I will mention, I mean, there's exercise, of course. I will mention sleep. If you're getting by on 6 hours of sleep a night, you're on average 190% more likely to develop hypertension, 110% more likely to develop severe depression, 63% more likely to develop diabetes. You'll take 11.5 days more sick leave a year than people who are getting 8 hours of sleep. We don't sleep for no reason. Sleep is kind of fundamental to our health and well-being. If we're not getting adequate sleep, we're not going to be working effectively, making decisions effectively. So and by the way, the last hour or two of sleep is probably the most important out of those 8 hours. The kind of dozy, dreamlike state is probably the most important in terms of well-being. And of course, learning and growing. You know, we're in a business where we can continue to learn and grow. My mum is 92 this year. She grew up in Llansamlet in South Wales. And she told me 4 weeks ago, she's joined U3A because she's taking Welsh lessons. Yeah. So continuing to learn and grow is really important to our health and well-being. As Perpetua said, being present, we know that the more time people spend ruminating about the past, being anxious about the future, the less present they are. The less present they are, the less they see the beautiful landscape this morning, the beautiful moon last night, the faces of their loved ones, hearing the music that they've got on their headphones as opposed to just kind of hypnotically walking through the world. The more we're present, the more we practice being present, the healthier we are. And giving to others has a profound impact on our health and well-being as well. And we work in a business which is about giving, caring for other people. So the more we can create contexts within our workplaces where people are able to do that effectively, the better it is for health and well-being.